Welcome to the Million Hearts webinar brought to you by the National Forum for Heart Disease and Stroke Prevention and ACOEM. I'm Keith Mason, Executive Director of the National Forum, a national organization of organizations across the private, public, and nonprofit sectors working collaboratively to prevent heart disease and stroke. The National Forum is very happy to be partnering with ACOEM, a National Forum member, to connect you with the Million Hearts team to bring you information and possible opportunities for your organization's engagement in helping Million Hearts reach their overall goals. With that, I will turn it over to Barry Eisenberg, Executive Director of ACOEM.
Good morning or good afternoon, everyone, and again, welcome to the Million Hearts webinar, Improving Workplace Cardiovascular Health, a collaboration between employers and government initiatives. My name is Barry Eisenberg. I'm the Executive Director of ACOEM, and on behalf of ACOEM, it's my pleasure to welcome the 240 plus ACOEM members who registered for this event and to our other special guests. ACOEM was honored to have been invited to join the National Forum in the summer of 2011. This webinar is a good example of the value that our partnership can offer to our members, and ACOEM looks forward to contributing in a variety of ways to the mission of the Forum over the coming years. We have an outstanding program for you today, so let's get right to it. And we're grateful to our three speakers who have volunteered their time to be with us. Our first speaker will be Janet Wright, MD. Dr. Wright is the Executive Director of Million Hearts, a U.S. Department of Health and Human Services initiative with the explicit goal to prevent 1 million heart attacks and strokes in 5 years. Dr. Wright has served as a Senior Vice President for Science and Quality at the American College of Cardiology. She's also served on the college's Board of Trustees and chaired their task force on performance assessment and recognition. Joining Dr. Wright in the first presentation will be John Michael O'Brien, PharmD. Dr. O'Brien is a Senior Advisor to the Million Hearts Initiative. He came to Million Hearts after helping to launch the HHS Partnership for Patients. Prior to joining the department, Dr. O'Brien was a professor of clinical and administrative sciences at the College of Notre Dame School of Pharmacy and a health policy fellow in the United States Senate. Our third presenter will be Jason E. Lang, MPH. Mr. Lang is the team leader for workplace health programs, where he has managed projects and provided leadership for the CDC National Center for Chronic Disease Prevention's Workplace Health Initiative. Mr. Lang previously worked for the Maryland Department of Health and Mental Hygiene in Baltimore, where he helped establish Maryland's comprehensive cancer and tobacco control programs, as well as organizing a statewide physical activity coalition. Mr. Lang received his MPH and MS degrees from the University of Michigan in Ann Arbor. Dr. Wright, the floor is yours.
Thank you so much, Barry. It is a pleasure to join you all today and to talk about Million Hearts. As Barry mentioned, we have a very explicit goal and timeline, that is to prevent 1 million heart attacks and strokes in 5 years. I want to share with you the rationale for why this target was selected and how we're going to go about it, and then I will turn the presentation over to my colleague, Dr. O'Brien. As you see on the second slide, and I believe that you all know this, heart disease and stroke kill more of us than anything else in the United States. About 2 million heart attacks are suffered each year and strokes, and 800,000 people die. As it turns out, about 2,200 people die each day from heart attack and stroke. And it affects us at younger ages as well as older ages. This disease is leaving big holes in our families and in our communities, and it is also profoundly affecting our economy. $444 billion in health costs and lost productivity translates into more than $1 billion a day. It's also 1 out of every $6 that's spent in treatment of health care. And the other thing is that nowhere else than cardiovascular disease does our racial and ethnic disparities appear so great. So we know this is a high-burden disease, both from the trauma in families and communities, but also in our economic budget. But the thing about the treatment of, or the prevention of heart attack and stroke is that the scientific base, the evidence for what can help us prevent heart attack and stroke is quite sound. We know that a number of lifestyle and behavior changes can result in a marked reduction in heart attack and stroke. We also know that medications can benefit for those who have high blood pressure or who've had an event such as a heart attack or stroke, or for those who have high cholesterol or a habit of smoking. So in order to prevent 1 million over a 5-year period, Million Hearts has focused on the ABCs. Aspirin for those at risk for heart attack and stroke or at risk for events. Blood pressure control, not just checking it or screening for it, but actually controlling that number. Managing the cholesterol, and smoking cessation. So on the slide that you're looking at now, you'll see at the population level for the United States, we're not even getting to 50% performance on very simple, straightforward measures. We're at 47% for aspirin adherence. The statistic that scares me the most on this slide, or disappoints me the most, is that the smoking statistic is actually for those who have already decided to stop smoking. Only 23% are being offered the counseling and the medication replacement therapy that has been shown to be effective. So it's a high-burden disease. We know what to do, and we're as yet not performing at a level that we know we can achieve. And that's why cardiovascular disease has attracted national attention and is now the topic for this national initiative. On the next slide, you'll see how we're approaching tackling a very audacious goal in a short period of time. 2 lanes for us. One is on the community prevention side, which is to try to reduce the number of people who need treatment. And on the clinical prevention, if someone does need treatment, we want to make sure that they get the optimal care. On the community side, we're focusing on reducing tobacco use and exposure to smoke, and on the nutrition side by decreasing sodium consumption and trans fat consumption, working in the food supply. A great deal of this effort is occurring with CDC and FDA and other federal partners, including USDA. And I need to make the point that there are many other community prevention efforts that would be complementary. But when the scientists looked at what could reduce heart attack and stroke in a short period of time, these interventions are the most powerful at the community level. We certainly are highly supportive of sidewalks and access to gyms and planting up the food deserts and many of the other community prevention efforts going on, either in organized initiatives across the country or in local communities. But for preventing heart attacks and strokes in 5 years, these are the most powerful levers. So the next slide shows on the clinical prevention side, we're focusing on 3 main areas. The first is to make the ABCs, the aspirin, blood pressure control, cholesterol management, and smoking cessation, a simple, uniform set of measures. For those of you who have contact with the medical system, you know right now doctors and nurses and others are swimming in all types of measures. And blood pressure measures, for example, have not been made uniform across systems. That work is going on at a policy level. That's part of the work of that first domain, but the other part is in order to drive performance, we want to create the right incentives and align those incentives with high performance, both for those who are delivering the care and for those who are receiving that care. That work is ongoing now, and I'll show you a slide in a minute that shows some of the levers that are going on in the federal family to help make that uniform, simple set and make sure it's incented. The second big area of work for us is in fully deploying health information technology. We're asking clinicians now to take care of a population of patients, my patients with heart failure or my patients with high blood pressure. In order to do that, they need the functionality of a registry embedded in their electronic health records or in their other support systems, so they can actually analyze how they're performing and how that group of patients or people are receiving their care. An additional component of health information technology is smart clinical decision support that's embedded within the flow of care so that in an interaction between a professional and someone seeking care, there are no gaps, that we never miss an opportunity to deliver the best evidence-based guideline care at that interaction. But all the health care is clearly not for these medical conditions delivered in a medical setting. Those of us who take medicines need reminders. We need reminders to get our medicine refilled, perhaps to get a blood pressure or cholesterol checked. And there are many health behavior nudges and hints and clues that can be delivered in electronic format that are really just beginning to be explored. And the final area of work in clinical prevention are the innovations in care delivery. These hold great promise. We're arriving at a point in healthcare where many new models are being launched. So the work of Million Hearts is to make sure that the ABCs are embedded in these new programs, that we are driving performance in the ABCs with aligned incentives, and that we've identified and fully equipped team members who are really critical to the delivery of this sort of chronic condition management. Those team members, including physicians and nurses, of course, but extend to pharmacists who have been grossly underutilized as very effective and powerful change agents. Likewise, there are health coaches and community workers, peer wellness specialists, and cardiac rehab nurses are another example of very effective change agents, and we want to make sure that the new models of care take advantage of those. So the next slide does show some examples across the federal family of initiatives that are already ongoing. They have one or more of the ABCs embedded, and in future iterations, we expect them to be even more closely aligned with the ABCs. The Physician Quality Reporting System actually rewards providers who report on clinical measures. Meaningful Use is a program sponsored by a combination of CMS and the Office of the National Coordinator to incent the meaningful use of electronic health records, and the ABCs are embedded there. This is just a small subset of some of the policy levers that currently exist and will be fortified over time. I think on the next slide showing the information technology activities, I think I've spoken to that already, but we're beginning as the adoption of health records, electronic health records, and other HIT progresses across the country, we're seeing enormous benefits in the closure of the gaps in care. Before I pass it over to John, I want to just say on the following slides, one showing messages to the medical system and another to the community, that the content here is important, but the real message is that we realize everyone, from every individual up through the professional health systems they work in, organizations and communities, state, local, regional, and federal governments all play a role in preventing heart attack and stroke. And we're beginning over time to refine our language and find out what messages resonate and are important for all of those groups. Ending with the community messages, this of course could be further defined and built out, and we will be working on that. So at this point, I will turn it over to my colleague, Dr. John O'Brien.
Thank you very much, Janet. I really want to build off that riff that you had going there about how everyone plays a role, and what a real treat it is to be able to discuss specifically how employers can contribute to the aims of the Million Hearts Initiative, specifically as it relates to both workplace wellness and corporate health. And I'm sure that you would agree that this shouldn't be the conversation that we have with this group, but rather will hopefully be the first of many conversations about how we can work together. And perhaps the first way that we can all work together is to sign the pledge at millionhearts.hhs.gov. The new website has been launched and will soon be a place where we can not only provide information about the initiative, but also include links to new information, new events, and even highlight success stories that are happening out in the field, hopefully including some that will come from our colleagues in the occupational medicine and employer community. Of course, central to the aims of Million Hearts is the ability to align existing employee health initiatives and programs with the Million Hearts goals both via workplace wellness and employee benefits. And I think the more opportunities I have to interact with your specialty and your community, the more I better understand that you are the interface between clinical prevention and public health, not only because of the science that you're developing, but also because of the sheer amount of time that employees actually spend in the workplace, and that any advice or care regimen that they're provided by a healthcare professional ultimately has to be implemented or adhered to in the context of real life. So you can certainly help and support this initiative by educating employees about the ABCs. And that's not just the importance of aspirin for those who need it, blood pressure control, cholesterol management, and smoking cessation in terms of reducing the risk of heart disease, but also educating employees about the availability of resources and employee benefits that can help them ultimately achieve better health. And hopefully, again, by employers communicating to employees about the resources that are available to help them as they attempt to quit smoking, we'll be able to drive those low numbers up. Ultimately, by creating healthy workplaces and leading from the top in heart healthy behavior will be the opportunity for employees to feel that they are part of a community of health. The ability to go beyond gyms or policies that support heart health and actually create communities that provide each other with the peer support to help continue the pull-through of the healthy behavior that Janet described is a key activity. And of course, improving coverage of clinical preventive services and offering incentives to employees, I think are an important component of the innovations in care delivery that Dr. Wright described earlier. So the ability to experiment with things as it relates to value-based insurance design, I'm sure this community is well aware of the value of things like waiving copays or offering incentives to employees for actually adhering to their medications or achieving their blood pressure and cholesterol goals. As we look at this not being our last conversation together, potentially some future questions that we can run on as we interact with each other throughout this initiative and beyond is to identify together what's working. We would love to be able to identify from your specialty just exactly what you feel the great success stories are and what the best practices are that we can ultimately put through the very networked networks that are part of the Million Hearts Initiative so that other people can benefit from your learning and ultimately make a difference nationwide. We're also very interested in what's not working and your rationale for, well, we've tried this and this didn't work, and the ability to share in both these success stories and other learnings via learning collaboratives and other networks, again, is a central opportunity for us and all of our partners to work together. And then, of course, we'd love to make this conversation an important part of our asking, how can we help you? We are very lucky that we're working with experts across the entire federal family. It's not just CMS and CDC, but ARC and all around the agency. And we're very lucky to be able to have Jason sort of describe the work that we're currently doing at CDC and workplace wellness. But the ability to connect you with our experts and identify just what we can do to work together and spread these best practices and lessons learned is ultimately a key part of the quality improvement aspect of the Million Hearts Initiative. And with that, we'll go ahead and turn it back over to Dr. Wright to describe the rich public and private sector support.
Yes, we are, thank you, John, and we are blessed. This is a snapshot of the federal family, and I would tell you that across that federal family, there's somewhere between 47 and 52 current ongoing activities that will definitely reduce heart attacks and strokes across the nation. And they are all pointing those sunflowers toward this specific goal. We are also blessed with private sector partners, and I'm happy to say that this is a subset of those partners, some of whom have been with us since the launch in September, and others have joined since then. But you'll see a spectrum of partners across the professions, into consumer groups and industry and businesses. We know there's lots of room, and as I mentioned earlier, everyone has an oar to pull to help us prevent heart attack and stroke. I will close by showing where we are now at less than 50% performance and where we are headed. The column that is led by 2017 is that by January 1st, 2017, at a population level, we want to be at least 65% there, as you see, and down to 17 for cigarette smoking. The clinical target column refers to those folks who are already in a health system, and for those, the targets are actually even higher. But to make it really meaningful, when we get to the goal of preventing 1 million heart attacks and strokes, what will that mean? It means that 10 million more people will have their high blood pressure controlled. Double that, 20 million more will have their cholesterol managed optimally, and 4 million fewer people will smoke. By dropping the average sodium intake by 20% and the trans fat consumption by half, by 50%, the impact on the population and its risk, our risk of developing diseases that lead us to heart attack and stroke will be enormously reduced. So I'll close for both of us by asking you to go to our website. By taking the pledge, and we are counting those pledges, what you're actually doing is committing yourself to the effort of cardiovascular health, to prevention, and in supporting through your home, your organizations, your businesses, and your regions, work toward reducing heart attack and stroke. Thank you so much. And I believe I'm going to be turning this over now to Jason Lang.
Thanks, Dr. Wright. And I want to thank both ACOEM and the National Forum for the opportunity to be with you today and give you a little bit of an overview of the National Healthy Worksite Program, which is just one of those myriad of federal efforts that Dr. Wright touched on that works in support of the overarching goals of 1 million hearts. This afternoon, I'll start with a brief overview of the National Healthy Worksite Program, touch on the overall program goals and our outcomes of interest. Then I'll describe the number and types of employers that will be involved and where the program will take place, and then end with some additional detail about the specific programmatic components and structure of the program, and then give you contact information about how to stay connected to the program and where we'll be going over the next couple of months. CDC awarded a contract on September 30th under a competitive solicitation that was titled Comprehensive Workplace Health Program to Address Physical Activity, Nutrition, and Tobacco Use in the Workplace. This program officially started on October 1st of 2011 and will run for the next 2 years. Now, obviously, this title was a mouthful for anyone to have to spit out on a regular basis. So one of our first orders of business was to effectively brand and title the program, and so we are now referring to this effort as the National Healthy Worksite Program. And this program is really designed to assist employers in implementing science and practice-based prevention and wellness strategies that will lead to specific measurable health outcomes to reduce chronic disease rates. For most employers, chronic diseases such as heart disease, stroke, cancer, obesity, and diabetes are among the most prevalent, costly, and preventable of all health problems. And Dr. Wright did an excellent job of framing that economic issue case up for everyone with respect to heart disease and stroke. The National Healthy Worksite Program seeks to promote good health through prevention, reduce chronic illness and disability, and improve productivity outcomes that contribute to employers' competitiveness. Some of the principles involved in the program can be found on this slide. We envision this program to be comprehensive in terms of providing multiple intervention strategies to participating employers and employees that include behavior change programs, organizational policy, and environmental changes to the physical and social work environment. We envision it to be comprehensive in terms of utilizing interventions and strategies that address multiple disease risk factors concurrently significantly. The program will focus on physical activity, healthy eating, and tobacco cessation, but by addressing these risks, there will be many opportunities to talk about and address a number of other chronic conditions such as diabetes, hypertension, high cholesterol, as well as other health issues such as ergonomics and safety. And lastly, it will be comprehensive in terms of engaging and impacting all levels of the organization, from frontline employees to middle management to senior leadership, as well as the organizational culture. Given that chronic diseases are the leading cost drivers for many employers as well as the nation as a whole, our goal is to provide program activities that are designed to reduce chronic disease risk by initiating changes in lifestyle and sustaining those changes over time. We will be capturing a lot of process and outcome evaluation information, principally using the RE-AIM framework developed by Dr. Russ Glasgow, to better understand sustainable and replicable practices so that the efforts of the employers participating in the program can be continued after the program ends. And we also want to document unique challenges for employers, particularly the smallest employers who will participate in the program, so further development of best practices can occur, and as Dr. O'Brien mentioned, can be shared broadly with this many different interconnecting networks of organizations that are concerned with workplace health. And lastly, we want to promote peer-to-peer mentoring among the employer community. We feel that participating employers will have many stories to tell, and we want to capture and share those, as well as empower participating employers to be role models to others. Through some of our technical assistance provisions, we will also explore opportunities for the employers to learn from others in the business community who have successful workplace health programs in their own right, or other national experts that know from years of practice how to achieve the goals that we've set out for ourselves. In terms of outcomes, we will know if we've been successful if participating work sites have put all the program elements in place and they are working effectively, including all of the programmatic, policy, and environmental support strategies that will assist employees in adopting healthy lifestyles and will support a culture of health for the organization. We'll be successful if key success drivers with respect to building and maintaining high-functioning programs have been captured and broadly shared to a diverse group of interested stakeholders. If participating employers and employees are more aware and knowledgeable about healthy behaviors, and linkages have been made to community organizations that can support them in healthy lifestyle activities. And that there will be more opportunities at the end of the program for health promotion made available to employees through workplace and/or community activities to support and sustain behavior change than were available at the beginning of the program. This program will involve up to 100 participating employers. These participating employers will represent different size categories in roughly equal numbers. The smallest employer group will consist of employers with less than 100 full-time employees. There will be a mid-size employer group that will have employers with between 101 and 250 full-time employees. And our largest group of participating employers will have between 251 and 1,000 full-time employees. It's important to note that while we will cap the large employer group at 1,000 employees, interested employers who have more than 1,000 employees are still eligible to participate if they nominate a specific work site that doesn't have more than 1,000 employees, and that work site can then be the representative of a larger organization. This individual work site must have the ability to implement all of the program components and fully participate in the program, meaning it must be an independent business or autonomous unit of the larger organization, and that could be demonstrated by the ability to set local policy and procedure without corporate oversight or approval. When looking at the national data on employer workplace wellness programs, employers, particularly in our small and mid-sized group, tend to be the most underrepresented in terms of developing and implementing comprehensive wellness programs, and so we think we're targeting a group that would really benefit from the activities that we've proposed. Our employer participants will be further organized into groups of up to 15 employers, each representing a local program site. There will be 7 local program sites spread across the country, and the employers in each of these 7 communities will represent all 3 of our size categories as well as various industry sectors. So on this slide you can see where our 7 communities are and where the National Healthy Worksite program will take place. Our overriding goal in selecting the communities was to find areas with a high health need and disease burden, as well as some well-developed community infrastructure and capacity to which we could align ourselves in support of the employers who are participating in the National Healthy Worksite program. This, we feel, will enhance the chances of success for the employers during the 2-year program period, as well as improve the chances of sustaining and enhancing their worksite health program after the program ends. So in terms of what the program looks like, in a nutshell here, we will assist employers in building a comprehensive program that follows a basic public health approach. First, we will seek to understand what the key health issues are amongst each of the participating employers and their workforces. We will do this through an assessment process where we will also try to understand the relationship between the individual worker and their work environment, take a look at health-related policies and their existing capacity, take a look at labor management relationships, look at the broader community in terms of what's available to the workforce in that particular area. And then following all of that data collection and analysis, we will work in lockstep and partnership with the participating employers to systematically decide and plan how to address those key health issues. We'll set goals and priorities. We'll determine roles for individual employees and leadership in the company, such as wellness champions, wellness committee members. We will employ multifaceted comprehensive approaches along our 3 main domain areas, whether they're individual or group behavior change programs, organizational policy, or environmental supports. And lastly, we will determine if the interventions and activities that have been implemented are having the desired effect through an evaluation process. Although we need to be concerned with top employer needs such as cost containment and productivity, we recognize that seeing this type of return on investment may take several years, and so we are going to pay particularly close attention to improvements in health risk and health behaviors, as well as the organizational changes that happen in terms of practice and culture. All of these activities will be supported by a workplace infrastructure that will emphasize systems such as data systems and communications, linking business operations to health outcomes and goals, integrating health and safety together, and management systems that will seek to engage all levels of the organization. The next couple of slides will show you in a bit more detail each of the main program elements. The assessment phase of the program will operate on both an individual level to understand employee health behavior, health risk, and current health status, and we'll collect this information through a combination of approaches that includes health risk appraisals and biometric screening, as well as surveys to describe employee needs and interests with respect to what they'd like to see in a workplace health program. On the employer level, we will work with key informants and leadership to conduct an organizational assessment, which will include a cultural audit, an environmental audit, and a survey of current workplace health program policy and practice. As I mentioned, with respect to the individual employee assessments, biometric screening will be done, and these are the following variables that we will focus on in terms of the biometric screening. This will help us identify employees that are at a high risk for things like diabetes, hypertension, or high cholesterol, and we want to identify them so that we can appropriately refer them to prevention or disease management programs, treatment, or care that will be available either through the worksite directly or in some organization in the community. We'll also use the screening results to provide immediate individual feedback to employees following that screening opportunity and treat it as an educational opportunity for these employees to learn about their ABCs, to know their numbers, and that obviously is one of the goals that Million Hearts has set out for itself. The planning and infrastructure building phase will consist of establishing, among other things, a broadly represented workplace health council or committee that will bring folks together from all levels, departments, job series, to actively plan and manage the workplace health program. Will consist of developing community linkages and partnerships, which will go a long way toward overall program sustainability. After we complete the 2-year project, we will work with employers intensively on developing a 3-year strategic plan, and given that our program is only 2 years, that program will obviously outlive the activity that we are doing, and really through a number of training opportunities, position employers and their employees to have the knowledge, skill, and capacity to be able to implement activities after we are done with them. The program implementation phase will consist of those individual programs and organizational policies and practices that will allow workers to adopt and maintain healthy lifestyle. Again, this supports one of the main goals of Million Hearts, in that the interventions and activities will be geared toward empowering workers to make healthy choices, such as avoiding tobacco and reducing the amount of sodium or trans fat that they might eat. So the key aspect with respect to program implementation here is that we will use a combination of strategies, including individual behavior change programs, as well as organizational policy and environmental support, which will be used to maximize both access and opportunity for workers to make those healthy choices. There are a number of different menu of options in terms of the specific strategies and interventions employers will be able to choose from. So in terms of those individual level interventions, participating employers may decide to implement weight management programs or offer tobacco cessation counseling through a quit line or health plan. One of our goals will be to move individuals who are identified at high risk and move them into a lower risk category from the beginning to the end of the program. This chart shows our logic flow in terms of how we will go about identifying and referring those people. Obviously, if you're identified at low risk at the beginning, you'll be referred into a general lifestyle maintenance program. If you're moderate or high risk, the employee will be referred to a physician to verify those results, and if still considered moderate or high risk based off of the biometric variables we'll be looking at, they will be assessed for their readiness to change. And if ready to take action, will be referred to the appropriate case management, disease management, or medication management programs. If they are identified as not being ready to make a change, we will still offer them health coaching and regularly engage them so that when and if they are ready to be referred into one of those case or disease management programs, we can immediately do that through the National Healthy Worksite program. These are some of the organizational policies that participating employers can pursue. They include things like tobacco-free campus policies, or looking at how the organization purchases and makes food available to employees, either through cafeterias, vending, or snack bars, implementing a policy that limits the purchase of foods high in sodium, calories, or trans fats, and conversely promotes food that are low in these is one strategy to make more healthy choices available through the worksite. In terms of environmental support that focuses on changing the physical or built environment or the social environment, they're listed on this slide are some of the opportunities that will be available to employers who participate in the National Healthy Worksite program. Employers could pursue a menu labeling strategy. They could bring a garden or farmer's market to the worksite to make more fresh fruit and vegetables available, or they could establish walking trails with maps to provide opportunity for physical activity. The last program phase will focus on evaluation, and we will be interested in documenting improvements made to both individual employee health as well as improvements in the organizational health and safety culture. We will conduct pre- and post-assessments at least 12 months apart on all of the different survey instruments or screenings that I touched on briefly, and we'll pay particular attention to the strategies and practices that were used to put the program interventions in place, and document what particular successes or challenges were noted so that lessons learned can be broadly collected and shared to employers inside and outside of the program. The Research Triangle Institute is leading our national evaluation of the program. Again, we're principally using the RE-AIM framework to document and better understand both the reach, effectiveness, adoption, implementation, and maintenance of the different programmatic policy and organizational and environmental support strategies that we'll be using. And they will document, again, and synthesize that information and make it widely available through things like case studies, success stories, or published manuscripts. Lastly, I wanted to touch on the training and technical assistance that will be made available to both employers directly participating in the program, as well as interested employers and organizations that come from one or more of the community sites, as well as nationwide. This will be a core component of the program and will involve a lot of peer-to-peer mentoring and community partnership building, recognizing that the demand for participation in the National Healthy Worksite program probably will exceed the supply that we have available. All of the training that we're doing directly with employers participating in the program will be made available through webinar or other distance-based learning opportunities to anyone outside of the program that wants to participate in those. This training will be complemented by access through our program website to the specific tools and resources that are being employed in the National Healthy Worksite program or generated by the program as we go through the process. And where you can find that information is listed on this slide. We have two ways to get to our program website, as well as our program mailbox. I encourage anyone on the call today who has an interest in staying connected to the program as it moves forward. You can send an email to the program mailbox and ask to be added to the distribution list. And that way you will receive information about training opportunities, our program newsletters and other program communications, as well as any updates of new information that we have available as the program develops. We are also currently in the process of certifying eligible employers to participate directly in the National Healthy Worksite program. So for those employers that you work with or employer groups that you work with, particularly if they are in one or more of the community sites and you think they may have an interest in participating, you can direct them to the program website where right on the home page there are instructions and eligibility guidelines for how employers can put their name into the hat to be considered for program participation. And we expect to make our selections of those participating employers in May of this year. And again, for those employers who are not eligible or otherwise not interested in direct participation, they can be referred to the program website to take advantage of the myriad of training opportunities that we will be rolling out starting this summer and which will continue through all of next year as well. So that's all I have for today. Thank you very much, and I will turn it back over to the moderator for Q&A.
Thanks, Jason. So for the attendees who would like to submit questions, we have some already in the Q&A panel that have been typed in. Please continue to send those in if you have them. Also, if you'd like to submit a live question over the phone, now's your opportunity. So if you'll notice the participants panel where your name is located, there's a toolbar just below your name. There is a little hand icon which will allow you to raise your hand. Click on that button. I will see your name and I will unmute your line individually. You can go ahead and ask your question at that point, and then after your question has been answered, or if you'd like to withdraw your question, click on that same button and that will lower your hand. And we have our first questioner. Tyann?
Yes.
Your line is open.
All right. Yes, I'm Dr. Hamedi from Overland Park, Kansas, and all this was very interesting. Thank you very much. I was wanting to know, is there a possibility of being able to get the slides to look over this, to get some of the information too, you know, and just to be able to stay in closer contact with you all?
Well, this is Barry at ACOEM. I can answer that, and the answer is yes. We will be posting not only the slides, but we'll be posting the audio version of this presentations. I expect that we'll have that done sometime tomorrow, but we'll be sending out a notice to the full ACOEM membership alerting them to that availability.
Wonderful. Thank you, Barry. I appreciate that.
And Robert, your line is now open.
Hello, everyone. It's Robert Naparstek in Providence, Rhode Island. My question is, how much overlap do you think there is with ACOEM's present excellent program of health and productivity management, where cardiovascular would be one portion of that?
Well, this is Barry from ACOEM. I can give you my perspective on this.
Sure.
Certainly there's some overlap. I think in many ways the goals and the objectives are the same, but there's so much work to be done. I don't see us getting in each other's way at all. And I think as the National Healthy Work Program goes forward, we'll find, as we are today, lots of ways to collaborate and make sure that our members and other physicians are getting the best of the information that's being offered through that program, and that ACOEM continues to develop on its own.
The point about what ACOEM has done so well, I think, is demonstrate the productivity improvements and the integrated benefits improvement that an employer can realize with staying healthy at the workplace. I appreciate it very much.
Well, it's nice to hear you say that, and we're certainly going to continue.
Sure. Thank you.
Okay, we have no other phone questions at this point where we can actually unmute the line. There's one person, but their phone and web aren't synced up, so you can go ahead and move on to the typed-in questions.
Sure. Well, thank you. We had one question that came in, and I believe Dr. Wright would be the best one to address this initially, and it has to do with the metrics. And the question is basically whether the numbers that were laid out in the slide presentation to reach the million less incidents are cumulative, or whether any one of them in and of itself would help attain that goal. Didn't get Dr. Wright immediately there. Should I move on to another question?
Let's see if we can unmute that line. So,
can you hear me?
There we go.
Oh, and I was giving such a brilliant answer to myself. So let me take a quick try at that again. All right, so it was a great question. I'm glad you asked it. I wish I had shown a slide that I ended up deleting last night before submitting the set, but I'll refer you to a study done by Tom Farley out of New York City. It actually graphs out the impact that high levels of performance on the ABCs can have, not just on the prevention of events, but actually on the prevention of mortality. And the most powerful lever among the ABCs at a population level is blood pressure control. If, say, we got to 65% of blood pressure control, cholesterol measurement, aspirin use, and smoking, all of those cumulatively would result in a little over 1 million strokes and heart attacks prevented. But the message, the take-home message from this one slide and from the study is that any one of those will have a dramatic reduction in mortality over time, given that they were at high levels. I would just say one other thing, because I would imagine that it's on your minds. Many people have asked us if we know that the rate of mortality from cardiovascular disease has been falling for the last about 8 years through both about 50% community prevention efforts and about 50% clinical efforts and interventions. And people want to know, is the million sort of just along for the ride? And it is not. We are predicting 1 million additional events on top of what we hope will be a prolonged reduction in heart attacks and strokes in deaths. The wild card, of course, is that as our population becomes increasingly obese and we have increasing numbers of diabetics, and we see that at younger and younger ages, will that drop that we've seen in mortality over the last 8 years or so be sustained and perpetuated, or are we actually going to start to see some upticks in that death rate?
Well, thank you, Dr. Wright. Please stay on the phone and stay unmuted, because we have another question coming your way, and that has to do with aspirin. The question was raised as to whether there is a good aspirin risk calculator available that is being recommended for point-of-care use.
That's another great question. Aspirin can be such a confusing thing, both for those of us who might need to take it and for the professionals that are trying to advise people. I would direct you to the Million Hearts website. We have information there about aspirin guidelines. For Million Hearts specifically, the aspirin recommendations come from the National Guidelines for Secondary Prevention. The U.S. Preventive Services Task Force has issued guidelines for aspirin for primary prevention. The good news that I've heard lately, about 3 weeks ago, I heard that a health collaborative in Michigan has taken on the task of developing a 1- or 2-pager that's both for the professionals and for the rest of us, translating those complicated guidelines into a simple set of advice, if you will, about who should and who need not take aspirin and what the risks and benefits are. So they have promised to share that with us, and we'll help publicize that and disseminate it through our website.
Great, thank you. I think we might have time for one more question. And this one has to do with the reduction of sodium intake and the validity of the scientific basis, which would indicate that a general reduction in sodium intake is really important for the general population.
Yes, and I'm delighted that you asked this question because it gives me a chance to announce that just today a new MMWR has come out from CDC along with something they call vital signs on sodium. So it captures the current thinking about sodium as well as summarizing the impact that sodium reduction can have across the population. I just heard within the last hour that that's available on the CDC website at cdc.gov. Also will be available on millionhearts.hhs.gov. And I have to tell you, as a practicing cardiologist, I would advise lower sodium diets, particularly for my patients who suffered congestive heart failure or hypertension. But I really did not understand at a population level that most of the sodium excess that we get, it's not in what we add at the table. It's in processed and restaurant food. And so the efforts directed with the food industry and the restaurant industry to gradually, incrementally lower that sodium will have a much more profound effect, not only on the treatment of hypertension, but actually the prevention of hypertension.
Great, thank you. And maybe we just have time for one more question. I believe this one would go to Mr. Lang about if you could go over the materials you presented on how employers could choose to participate in your work site, in your National Healthy Work new initiative.
Sure.
How do they actually choose to enroll?
Sure. There's a couple different ways. If you'd like to enroll and put your name in the hat for being selected as one of the 100 participating employers that we have, if you go to the program website, cdc.gov/NHWP, there's a link right on the home page that asks you to review the eligibility requirements. And then after you have read them, if you think that you meet the eligibility requirements, there is a link that says meets requirements. You click on that, submit your contact information, and then we will follow up with you in the next couple months to conduct a telephone interview and go through the process of making our final selections. If you are in a community that we have a program site in and want to just maintain a connection to what's happening in that community, be a part of the community coalition that's going to be organized, or just have access to the training and ongoing program communications that we have, there is a link on the home page that says does not meet requirements, and if you click on that and provide your contact information, you'll be captured on our distribution list to get you that information as it becomes available.
Well, unfortunately, I think our hour has just about been exhausted. I want to thank everyone again for participating. Especially want to thank the National Forum for helping to make this webinar possible. Before we close out, I would just ask our speakers if they have any final comments or observations, and remind everybody that we will proceed to post both the audio and PowerPoint versions of these presentations on the ACOEM website, probably within the next day or two.
Great. This is John O'Brien. I just wanted to say thanks again to everyone who participated and for hosting us and for their questions. I'll also add that the final version of the slides that we'll share, that you can share with all the participants, will also include contact information so that anyone out there who wants to specifically work with us beyond signing the pledge can do so in short order.
And I'd echo the same comments. Thanks to everyone for your participation and interest today. If you have programmatic questions about our program or want to explore ways to get connected to it either at the local level or up here at the national level, the program mailbox that was on the slide set, which you have access to, is a good place to route that inquiry, and we'll get back to you on it.
Great. Well, again, thanks to everyone, and we will now be ending the call.